So I came up with what I feel are sort of the basic rules of the doctor-patient engagement. And in real estate, in real estate, there's an old saying that the most important things to value real estate in buying and selling land or housing or commercial property is that it's all about location. Location, location, location is what drives everything in real estate. And my contention is that in healthcare, really it's all about communication, communication, communication. And this really extends not only into the areas of establishing informed consent for what we're going to be doing with our patients, whether we're giving them a surgery or some medication or psychotherapy or anything else, but it really gets to the issue of helping the patient through the illness. And so it's communication, communication, communication. I would argue that it ultimately is the fundamental issue in healthcare in what we do. It doesn't matter how smart we are or what drugs we have access to or what surgeries we may be able to do with our hands. It ultimately comes down to our ability to communicate that effectively, compassionately, and efficiently, ultimately, to our patients. Next slide, please. There are many, many different studies in the literature about the importance of patient-physician communication. I've just picked out a couple of examples here to make some of the points that I think are important. But many studies have shown that even when you control for other aspects of healthcare, the severity of illness, severity of a cancer or some medical disease, and you control for comorbidities, that the quality of healthcare communication has a measurable and positive effect on outcomes. And the patient's key concerns have to be addressed directly, they have to be specifically asked for or solicited, and they have to be addressed in order to have really an effective communication, an effective healthcare relationship. And the classic example is that of the cardiac surgeon. I can say this as a surgeon, and that is that cardiac surgeons are, shall we say, not known for their bedside manner. They may be quite good at performing vascular surgery on the small arteries and veins around the heart, but they're not typically known for their warm and fuzzy demeanor. And I don't know if the cardiac surgeons in that part of the world are different from the cardiac surgeons here, but I suspect not much. Now, if you take two different cardiac surgeons, both of whom have equal skill sets, technical ability in doing the technical work that they are meant to do, and one is thoughtful and compassionate and has really a good rapport with his or her patients, and the other is not, then, you can see where I'm going. There are measurable differences in the quality of the outcomes, measurable outcomes in terms of angina, recovery, etc., in patients after cardiac surgery. So it's important that the clinician really understand patient's perspective on his or her illness. Not just the doctor's perspective, but the patient's perspective. I do a lot of studies in quality of life measurement in patients with various cancers and benign diseases. And one of the axioms, the fundamental axioms or principles in quality of life research is that you can't ask the doctor. The doctor certainly has an opinion about the patient's quality of life. And it's usually it's reasonable proximity of the patient's opinion, but it's never exactly the patient's opinion. And so it's really critical to talk to the patient and get his or her perspective on the illness itself. Next slide, please. The concerns that patients have, whether it's cancer or benign disease, are very, very far-reaching and broad in scope. And you may not necessarily, as a physician or a clinician, be in tune with them. Certainly, anyone who's been through experience as a patient or had a close family member as a patient, and really who among us hasn't, can get a perspective. I myself was introduced to medicine from the other side of the stethoscope when, as a teenager, I was diagnosed and treated for cancer when I was in university. And it introduced me to medicine. And I think that, while I wouldn't wish that on all doctors or all nurses, it certainly does give me a perspective when I'm approaching patients as to what they might be going through. And even some years later, I really can't shake out of my own memory the experience that I went through, and I try to carry that forward. Now, I don't think that every doctor has to go through a critical life illness to get that perspective. Hopefully we can teach that to our medical students and to our practicing physicians, but it's interesting the perspective that gives a person. There is, of course, the fear of death. And it can be anything as great as a major illness to something as small as a little bump someone feels behind the ear. The first place that people go, at least in my experience, is, what is this? Is it cancer? Is it going to kill me? And of course, the vast majority of what we do in medicine is to simply reassure patients that disease X, Y, Z, symptom A, B, C is not going to kill you. Sometimes we neglect to actually address that. We end up acting dismissive with the patient's concerns in our attempt to be reassuring, and the patient ends up going away not having gotten really what he needs. Excuse me. So there's this fear of death, of disability, of being mutilated in some way, and there is this ominous attribution of pain symptoms. The pains that patients get, they typically do associate with some serious illness. And that then engenders a basic distrust at days of the healthcare profession. It's unfortunate, really, that this has evolved in the way that it has, but certainly in the patients that I see, the way healthcare has evolved into much more of a consumeristic approach and attitude, with patients having great access to information now through the media and the internet and whatnot, is that almost at times there is this distrust of physicians, as though we have something that we're trying to sell the patient or to convince the patient of, when in fact, for the vast majority of us, we are simply there to try to help the patient. But there is this distrust, and there's a concern that patients have that they will lose independence. I think this is particularly true in male patients, but it's true for any patient. Patients don't want to lose their sense of wholeness, of completeness, their role in life, whatever that role is, whether they are a neurosurgeon or a chief executive of a company, or whether they are a blue-collar worker or a homemaker or whatever their role in life is, they worry that they're going to lose that, even if it's someone who's retired, whose role simply is to help with the grandchildren or to help with a disabled spouse. They worry a lot about that. For many patients, there is a denial of reality. Now, you have certainly the types of patients, the ones who think that everything is a life or death issue, but then you have the others who really try to just deny or unintentionally deny the symptoms and deny what's going on. And for those patients, this communication, I think, to establish that trust can really be critical and play an important role in helping the patient come to terms with the illness. There's grief, of course, fear of being taken away from home, and then other issues that are just unique to each individual patient. May I have the next slide, please? So, in doctor-patient communication, it is important to explore the patient's values, his or her cultural background, and his or her preferences. And the classic example from my daily work is in prostate cancer, when I'm counseling men about surgery and radiation and surveillance even for prostate cancer. I want to counsel them on helping them decide what their own preferences are. It turns out that for many diseases, there is a choice of options, of treatment options, and they may all end up yielding the same medical outcomes, but the quality of life may be different. And so it's really important for us as physicians to help the patient get in touch with what his or her preferences really are, because that may end up driving the decision-making. I think it's also important to avoid coming across as judgmental or scolding of patients. This is particularly hard to do when you're as a disease that's associated with a behavior, for example, smoking and lung cancer or bladder cancer, which I see. I have to resist the temptation to wag a finger and scold the patient for smoking, because at that point there's nothing that he can do about it. At the same time, I want them to stop smoking, but that's a separate issue. The patient wants to be reassured, though. The patient wants practical or pragmatic suggestions, and I think that sometimes patients benefit simply from having the opportunity to express or vet their concerns and their history. One example, and again, I apologize for always using urology examples, but one example is that of the patient with chronic prostatitis or benign non-infectious pain in the prostate. The fact of the matter is that apart from a small percentage of those guys that can benefit from antibiotics, there's not a whole lot we end up doing for them other than reassuring them. And yet there seems to be some kind of an inherent therapeutic value from establishing a trust, a rapport between doctor and patient, and allowing the patient simply to be heard, about the symptoms. And I think there's great value in that. And I think that that's a lesson that we can carry forward to other diseases, other conditions across the spectrum. Next slide, please. So it's important that we know what the psychology is of behavioral change. And there's a whole literature, sort of a small literature on this. But there is a psychology that's established for behavioral change and behavioral modification, and we have to establish a framework for any interventions that we do. There are 5 A's of patient counseling. They're listed here: assess, advise, agree, assist, arrange. So assessing the patient and his or her perspectives on illness, advising him or her based on our medical knowledge, agreeing or getting the patient to agree, coming to some kind of a consensus between doctor and patient as to what comes next, assisting the patient in dealing with his or her issues, and then, of course, arranging whatever we can. Now, very often the arrangement ends up being simply referring the patient to behavioral support, counseling support. At UCLA, and I don't know how it is where you practice, but at UCLA, we have mental health services, survivorship services for all patients with cancer here that we actually provide free of charge. And I make a routine recommendation, and I tell patients that I think anybody going through a major illness, certainly a cancer, but any major illness, ought to be in some kind of therapy. I mean, in the context of a busy clinic, there's only so much that you can do. You want to do as much as you can, of course, but there's really only so much you can do. And there's nothing shameful or embarrassing about referring a patient to professional counseling. And I do it all the time. And I actually insist that patients go just out of deference to me. And even if they don't think that they need it, almost universally they'll come back and say that support that the mental health professional is able to provide ends up being extraordinarily useful. Next slide, please. I think that there are some keys to successful doctor-patient communication, and one of them is that paternalism really is out. Now, that's not the way it used to be. When I was training in med school and in residency in the 1980s, this is really the way that medicine was practiced. You know, a patient would come in, they would expect the doctor to basically instruct them on what to do. Sometimes there was some choice. Usually the doctor would just say, well, here are the options, A, B, and C. I think we're going to do B. That was the discussion. That was it. Completely on its side. There's much more consumerism. But with that consumerism, there is a shared responsibility for decision making. And to a large extent, that actually unburdens the physician from having to shoulder all the weight of making the correct decision. And that ultimately, if a patient chooses surgery or radiation or chemotherapy or one form of insulin versus oral diabetic medications, or, you know, fill in the blanks for whatever disease you're talking about, if the patient shares responsibility in that decision making and he or she is well informed, and that's part of our job, then ultimately if there's something that is untoward or something negative that happens, we don't feel quite as bad because the patient made an informed decision with us. And so today it's all about shared decision making, doctor and patient, nurse and patient, doctor and patient and family, whoever is in the patient's immediate social matrix. And I think that it's really, really critical to pursue that as much as one can. Next slide, please.